Gũkũ mũbango wa motungata ma ũgima wa mwĩrĩ wa SHA ũthiĩte na mbere na gũkĩrĩrwo nĩ atongoria matiganĩte, mũnini wa President Professor Kindiki augĩte mũbango ũyũ nĩ wongereire mbeca cia UHC kuma mirioni 8 nginyagia mirioni 32, akiuga ũũ nĩ kuonania andũ aingĩ makĩria nĩ maragunĩka na mũbango ũyũ ũkĩringithania na wa NHIF.
The universal health coverage, Taifa Care, is about the health of the people of Kenya. So the bottom line is about the people. Better quality healthcare for the people of Kenya. From 8 million to 32.3 million today. Isn't that a great progress in terms of universality? Because we have had a healthcare program before. NHIF had a public medical insurance cover, but 8 million, 32.3 million, a huge leap, and still counting.
Augete andũ aingĩ makĩria nĩ mahotete kũgunĩka na mũbango ũyũ, koguo thirikari yake ndĩhenetie a Kenya, akiuga nginyagia mũbango ũyũ wa SHA nĩ ũtigĩte kũhũrwo, kuona nĩ ũrahe mũingĩ motungata ma ũgima wa mwĩrĩ.
Universality of healthcare is a reality because of numbers, the number of Kenyans who have some form of medical cover, which may not be perfect, which is being perfected, which is being fine-tuned, but at least when they fall sick, they do not have to rely on quacks, magicians, sorcerers, and manipulative religious leaders, some of whom take advantage of sick people. They have a medical cover. That is what universality looks like. We are smelling it. It's around the corner. Some counties have achieved it, others are on the way. If you add those Kenyans who are on a private medical insurance, we are approaching 60-something% coverage. That is not a small measure. Compare it with other countries for you to understand. So President Ruto said we will reform this thing. Luckily, he expected the pushback would be there. But he promised the country that he will weather the storm, risk his popularity in the short term until we get this thing right, and his popularity will be back. Imefanyika, haijafanyika. The noises that you used to hear that SHA is not working, whoever is criticizing SHA now is whispering. But when we started, especially the initial months of rollout, it was terrible.
Kindiki augĩte nĩ mahotete kuongerera interns 24,000 mathibitarĩ-inĩ, akiuga nĩ gũthiĩ na mbere na kuongerera manathi 5,000 nĩguo kũgacĩrithia ũgima wa mwĩrĩ, na oho akiuga nĩ mokĩte na namba ya kũhũthĩrwo nĩ mũndũ o wothe ũrenda ngari ya naihenya ya gũkinyio thibitarĩ.
The national government has been able to post or to place 24,000 interns, medical interns, health workers, CHPs, medical interns, 262 registrars who have been facilitated to further their education and to specialize. But there is a commitment now which is being realized at the moment of hiring 5,000 nurses and midwives to protect especially our mothers, to make sure that we achieve that aspect of our health system. But we have also 922, the National Ambulance Dispatch Center, an emergency number to provide ambulance services to patients who have emergencies, who have medical emergencies. You get the ambulance. First of all, the number is toll-free. That 922 is toll-free. Secondly, it should link you to the nearest available ambulance. And we must make sure the ambulance is available in good time to save lives. But also it is attached, that package is attached to emergency treatment. The first 24 hours of emergency treatment should not be pegged on anything. Whether someone has a cover under SHA or not, they must be stabilized as now they get registered into SHA and other things follow. So again, around commodity and medical logistics, the ambulances, the commodity availability of drugs and so forth is work in progress.
Kindiki oho augete gwakinya nĩ macini cia kũrigita arwaru, thirikari yake nĩgũrĩte macini cia mũigana wa birioni 9.8 iria iraruta wĩra mathibitarĩ-inĩ.
Through the National Equipment Support Program, we have placed so far equipment worth 9.8 billion shillings in 239 health facilities in 44 counties of the Republic of Kenya. And that work is ongoing. Equipment you will not have imagined. CT scans, the MRIs, the lab equipment and so forth. There is a lot of equipment placement ongoing through a fee-for-service arrangement, whereby it is up to the person who owns the equipment to place the equipment, take care of the equipment, look for the consumables, make sure the equipment is working, maintain it, and the work of the patient is to come and get diagnosis. And once that diagnosis is done, the bill is sent to SHA, and SHA settles the bill. So it is up to the owners of the equipment to make sure the equipment is working, because if it's not working, they will not be paid. They are paid for every service that they deliver. So again, this equipment thing is work in progress. We have looking forward, we need to work on level 2 and 3 a little more, so because that's where much of the early diagnosis is done. And I think that progress is something we need to be proud of. So you have the people, you have the health workers, you have the equipment.
Ũguo nĩguo gũtariĩ. Handũ-inĩ ha Kiambu TV, rĩtwa rĩakwa nĩ Wangari wa Kamau.